Hey everyone, this is the Nips and Sips podcast show featuring me. I'm Dr. Jeremy Boyd and my partner in crime over there, Dr. Brandon Cruz. Today we're going to be talking about something that's been circling around the social media world and the research world. Chad Cook, who we talked about on a previous episode, a big researcher and professor in orthopedics and manual therapy, released the 8 demonizations of manual therapy, as you know, it seems on social media and current social media gurus out there, and also in the research that were manual therapy is under attack a lot, forcing potentially new grads or seasoned therapists to give up on it, and they're throwing the baby out with the bathwater, as it's commonly said on this show by Brandon. But before we get too much into it, it should be a fun little chat today. But Brandon, how's it going?
Going well over here, man. Yeah, guys, we're actually gonna do a different episode, and I saw this pop up on AAMP's Instagram feed. Which, if you guys don't follow AAMP, definitely give them a follow. They put out a lot of good stuff. And then, being that we had a couple times, we had talked and mentioned the initial, I guess, podcast with Dr. Jared Powell, with Adam Minkins and Chad Cook. And then we had our own, we threw our own 2 cents, or combined 4 cents into the ring there. And then when this came up, it was like, all right, let's talk about this while we've been on this topic. I think this article came out about a month ago, you said, and I think this would be a nice talk, especially as you go away for the next 2 weeks for a few weddings there. This would be a nice conversation to have. But I guess we'll go into our drinks as we normally do. What do you got on your end?
Oh, I got the Cisco Breweries, which is in Nantucket Whale's Tail Pale Ale, which has got a nice rhyme to it. I had a sign, a sign that you hang up in your home, bar from them for years, and I actually never had them before. So finally got a chance to get a 6-pack of them. So I'm gonna crack this open from my Fox Farm Brewery, which was in Connecticut, Rhode Island, one of the two. Pretty cool brewery out on a farm, really nice aesthetics. A lot of good farm ales over there. So I'll let you know my score in a minute there. Brandon, what you got on tap?
Yeah, I got a one from a former intern of mine, which is he's now going to be one of our new hires, A Cakes Trinidad. There, he got me a Jack Daniel's Honey a few months back. I think it was around Christmas time. So I'm gonna hit this open in honor of him here. He had got me that. I think he had got me a vodka Red Bull too. I had on the show, knowing that's one of my favorite drinks there. This is another one. He also got me another bottle. I'll save that for another episode. But that's what I got today.
Way to go, A Cakes. He knows the way to your heart there, or liver.
He does. And he's a baller too. So, all right. So what were your thoughts when you first saw this? Actually, I think you were aware of this article before I was.
Yeah, I saw it on, I think, LinkedIn. Zach Walston, who's also on the show, put up a nice infographic of it, summarizing the 8 demonizations. But definitely off the heels of that conversation between Cook and Meakins, I thought this kind of solidified things and furthered the points that Chad was bringing up during that show, which we previously released our points on it. I thought it was good. I mean, I thought he's honest with his whole viewpoints and everything like that. I thought it was really important for everybody to see, that these demonizations they're not valid. And I've come across students now. I've seen people on social media where they're hanging their hats on a couple articles here, or these sweeping generalizations of manual therapy. And I think this article, highlighted it's the thing, was it 3 pages, maybe 4?
A little more than that, I think 5 or 6.
No, 4, 5 or 6.
Well, 2 of them are references, so 6.
Yeah. So grand total, not that many pages for those people who kind of get, they're daunted by long research articles. This was quick summaries of things. And then, yeah, he just brings into highlights of the main points, which I'll just kind of bring up, one by one. Was one, manual therapy has no unique specific effects. That's demonization number one. Number two is use of manual therapy leads to patient reliance and dependency and subsequent low self-efficacy. That's Meakin's viewpoint. Chad brings that up as that's more of a blog than anything that's actually be researched. And if you look at Meakin's rebuttal, he brought up the 8 strawmans. He admits it to himself is that there is no research that, but anecdotally speaking, that's what he's seen over his career. I would say things are maybe a little bit different over here. And what are we comparing that to? Dependency on manual therapy, or dependence on opioid addictions, or hell, dependency on surgeries. I know some patients before they're in their mid-30s, they're already 5-6 surgeries deep for surgeries that are completely unnecessary. So is that considered dependency? Or reliance? But so we'll talk more about that. Number 3 was manual therapy provides only short-term changes, which do not equate to long-term changes. We'll talk about that. I think it really depends on your viewpoint of things. If we're not applying those short-term changes and making an immediate impact early on, and modulating that pain, does that person end up with chronic pain? But number 4, manual therapy techniques are based on outdated, inappropriate philosophies, that were derived to support a guru's theory. Chad Cook admits to that. Number 5, manual therapists lack skills in communication, reassurance, and empathy, which I, very much disagree with. That's highly not the case. All the manual therapists I've been around with, I had the benefits of going on fellowship training and seeing some of the best manual therapists. They're some of the best educators I've ever seen. Number 6, manual therapy does not fit within value-based care, which we talked about last kind of session. Number 7, manual therapy can causes as much harm as help. That's highly debatable. And number 8, we can identify candidates for manual therapy, which means the techniques are unnecessary. That can be said about just about any medical intervention, but those are the ones out there if you haven't had a chance to read it, so you're not completely lost. But Brandon, what about you? What were your thoughts?
Yeah, first of all, well written by Chad Cook. I really think he expressed things very well, articulated them better than I could ever hope or dream to. So when I read this, I was like, this guy's nailing it and presenting, both sides of the coin in a relatively unbiased manner. I think everyone has biases, good, bad, and different. So to say, it's completely unbiased is probably not true. But, like you said, one of his points where he talks about the dogmatic approach of philosophies and gurus, what's that, number 4?
Yeah.
He admits that, there's a lot of truth behind that.
Mm-hmm.
So I think it's well written. And I want to say, even before I go into it, I feel like this is, the battles, the turf battles, forget between professions, but within our own profession is becoming like politics, Republicans versus Democrats,
Mm-hmm.
right? Liberals, and so forth. But we have the exercise and pain science camps, and then we have the manual therapy camps, and then within manual therapy, joint based versus soft tissue and whatnot. I would think, at least you and I, and probably, some of the people in the same types of training, OCSs and residencies, fellowships, probably more so agree than not. And, we're trying to spin it, or not spin it, but present things, as unbiased as possible, and want therapists and want to improve the profession to move forward the way it needs to, and not just as we always say, throw the baby out the bathwater or fall into a camp. Our profession encompasses so many things. Why not use all of those things? And when you come to a point where people are saying this never works or this always works, that's where you need to, raise your ears, because nothing ever works and nothing never not works all the time. I don't know if that even made sense. But hopefully you guys got what I was saying there. It's about finding what patients this will respond to, or patients will respond to X intervention. It doesn't have to be manual therapy. And I really liked point 2 or actually point 3, demonization number 3, manual therapy provides only short-term changes, not equate to long-term changes. And we've all talked about the test retest, and things like that. But he even goes on to say, and I kind of highlighted some points here, is important to recognize these studies include manual therapy as the primary treatment technique, but not include a control technique to see if the effects were specific to manual therapy. He goes on to talk about how each patient has their own endogenous pain modulating capacity or response, right? Each person has their own ability to adapt to pain in a different way. Some people respond very quickly and some people don't, right? So using manual therapy to see if that person is someone who responds to this intervention is a great way. And then you use it as a test retest. He went on to use an example of a study done to prove or to talk about individuals' ability to adapt to pain. And it was, they stuck their hand, and they measured this. They immersed a patient's hand into a cold like bucket of ice water, and measured their symptoms. And the people that have better responses, or they're a better natural regulatory ability to adjust to pain, have a quick response to, let's say that first 10 seconds is awful with your hand in the ice. And any athlete who's ever taken an ice bath kind of understands this. The first minute sucks, but after that, you respond pretty quickly and you don't mind it too much. Versus the people who have trouble with adapting to pain naturally on their own are going to have a worse outcome and have a slower response to that. And if you think back into Crips, or what's that, RSD, right? One of the thing is, or even whiplash, they have an abnormal response to cold. So now we're putting a few things together, and we're just using manual therapy as kind of a control alt delete, or a way to help that person reset their pain system, right? Which, for people who say that there is not enough research, and we've talked about it a lot, and Chad talks about it here, that's probably the last thing, because there's so much research pointing at the neurophysiological effects and all the biochemicals and non-GABA receptors and serotonin and dopamine and all those biochemicals and brain chemicals that are altered with manual therapy and thrust manipulation, to be specific. That's like the one thing we probably can hang around, and that there is research with that. So those are like two of the things that really stuck out to me. And I really like that he was able to really kind of articulate that in a nice manner. I'll kind of pause on, some more of my ranting, what I liked. Jeremy, was there anything that kind of stood out to you in the article?
Yeah, I mean, there's a lot of things. I would like to piggyback once I saw that cold study, which was kind of interesting in regards to pain and everything like that. I'll talk about a Navy SEAL real quick. Their Discovery Channel did this thing about trying to assess the effectiveness of or what was it? So they pretty much wanted to see how elite Navy SEALs were, and they want to run through a battery of tests and then see how their bodies tolerate different conditions. So they put a Navy SEAL in an ice bath for an hour before the medical people were enough is enough, but he was fine. And he did this shooting course pre and post, and they actually did better post, which was just probably more for this to show because it was on Discovery Channel. It looked cool. But I treated this Navy SEAL once, and his response to pain was significantly different than I've ever seen before. He shattered his knee, and essentially it blew up, and they have a knee replacement, super young. But it was super scarred down and everything like that. But I remember pushing on his knee, and I felt pain just trying to push on him. That's how aggressive his was. And he is the first person who's ever told me to keep pushing. That's how much of a beast this guy was. And it felt like I was going to snap his knee right off. But that was like, just when I heard that study, that's how different certain people are versus certain people I've had with like ACLs. I can't even get them in the prone position to bend their knee. So try and take it like an understanding, maybe applying that study to try and get a gauge of your patients. But I think that's a little bit obviously cumbersome in the clinic, but it's just taking and understanding your patient's experiences and testing things out. There's plenty of times where obviously I have a manual therapy hat on. I've gone through fellowships, whatever it may be, residencies, and I want to try and modulate the patient's pain, and sometimes it just doesn't work. Sometimes it's just not what the patient needs at that moment. And it's being able to be, think outside of things and understand, yeah, this is multimodal. All right, manual therapy may not be the move. Maybe I should just get them warmed up and exercise. So, just kind of thinking of that, we shouldn't pigeonhole ourselves to, one tactic or another. But I thought that was kind of cool, kind of brought up some goodness. Well, wasn't great memories for that particular Navy SEAL, but nostalgic for me in a sense, based off of that. But yeah, I mean, kind of what we were talking about. I think it needs to be known that, manual therapy does provide that short-term change, and we're not trying to kid ourselves saying that, this is going to be, we crack your neck or we manipulate you, we put you back in place and you're cured for life, or these outrageous claims that, CO manipulations can cure multiple sclerosis, which I recently saw on Instagram. Is this a window of opportunity? But why not capitalize on that? I think a lot of people are missing that boat, that we look at these studies of, oh, what are the effects at 1 month? Was it 3 months, 6 months, and then 2 years or something of that nature? And as long as it's, the same 2 years out or 6 months out, it's like, why even bother applying it? Same goes for like the CPM machine. I think everybody got that study when we were in PT school, that CPM machines were pretty worthless.
Yeah. CPM versus passive range heel slide.
Yeah, I would say for most individuals, yeah, it's pretty worthless. It's why spend the money. But there are certain people where, they're too afraid to bend their knee. And if you don't give it to them, then they're coming in stiff as a board because they got 10 degrees of knee flexion. So why not try and figure out who that is? And, again, apply the right intervention at the right time. Even Meakin's like rebuttal, the strawman rebuttal about this particular article, he even says it's just like, we're doing well because we're challenging things. We're trying to push the profession. This should be welcome and that sort of stuff. So it shouldn't be as far as a demonization, but it should just get to some challenges and those sort of things. So I think that's these viewpoints, these debates are really beneficial for that, and understanding not everyone's going to fall in a nice, neat package, and we need to work around it. But I've been talking for a bit there, Brandon. Why don't you take
Yeah,
it?
you made a good point with the CPM versus passive range of heel slides. That article that was at least when we went to school in the 2010 to 2013 range, probably plus or minus a few years. I'm sure that article was passed around. I think, and this goes to Demonization 8, but I believe in that study both were effective, right? But heel slides was either slightly more effective, or when you measured it for cost, it was deemed more effective because it didn't have the cost associated with the CPM machine, correct? So Demonization 8 goes to, we can't identify candidates for manual therapy, which means the techniques are unnecessary. How you go from one end to all the way the other end is beyond me. But he talks about a great point, and basically that there was an error in this extrapolation. And I think now, at least in the social media world, but I even see it sometimes on the academia side the other way, where if it's, if the article doesn't say it, if it's not grounded in research, we can't do it. There's a lot of holes in research. There's a lot of paucity. There's, very few articles that are actually high quality that measure what we're really trying to look at and do, especially in the world of physical therapy. A lot of these studies are really, and when it comes to research, are really more so from pharmacy or pharmaceutical and or like medical practice, like MDs and things like that, but more so on the pharmaceutical side. So we're trying to take, stats and research from that and make it fit for what we do. But he talks about the error in this thought process and, identifying appropriate and definitive candidates for treatments such as surgery, injections, medication, exercise, cognitive behavioral therapy, physical therapy, manual therapy, you keep going. And there's a response, which he terms, there's a shared response, regardless of no matter what approach that you use. There's always going to be some shared response in which everybody has some sort of, response similarity to it. So it's called a shared response. No matter what intervention you use, there's probably going to be some negative or some positive effects, right? Which is why you see these null results in trials, right? And he obviously understands that better than probably you or I would ever hope to, being, the researcher that he is and, the experience that he has. But that shared mechanism, suggests that there's no superiority in interventions, across the board. But we as clinicians need to be able to understand research a little better, understand and what he terms a dirty secret, that we need to recognize that a majority of any musculoskeletal approaches are going to yield similar outcomes. And I think part of that is because not only there's input, right? And in physical therapy, we're talking about, movement most of the time. And if we know for most chronic conditions, especially low back pain or neck pain and things like that, if you move, you're just going to get better. But the other part is time, right? We look at these long-term studies, 6 months out, a year out, 2 years out. What's the common denominator? Time. We all know the body has a great ability to heal itself for most things. And we're not talking about pain. We're talking about healing functionally and kind of getting on and doing what you need to do. Time is a big factor that oftentimes goes overlooked or underlooked, depending on how you look at it. So I think that's, something not to highlight there. And we can't just be so hard and stringent. I think the last part I really want to get out in terms of this article is the that dogmatic approach, right? And we've both undergone residency and fellowship trainings where we learn the origins of stuff, but we've also learned, okay, we've evolved it, or how to evolve it, how to move away from some of that dogmatic approach. And the arguments out there, and we say Adam Meakin's, but there's a lot of different groups out there. I'll say the names. What's the I'm blanking on right now. What's the athletes group?
Clinical athlete.
Yeah, there you go. Clinical athlete is very anti-manual therapy, exercise only. I was a part of their group when he first started out. I was very happy when I spoke to him. He wants to move the profession forward. Awesome. Wants to, get people to squat when they're told they can never squat again. Great. But you're, again, neglecting one side of what we're able to do. And I can't get down with that personally. You have another gentleman on there who I've had back and forth with and likes to throw the baby out with the bathwater. That's, a common term that's thrown out there. And this is someone who did a residency at a very prestigious school. Why, he decided to go one way or versus the other, or, a more encompassing approach, I'm not sure. You and I have had kind of our back and forth with the movement maestro, and some of her stance with manual therapy or even residencies, not finding value in them, and then spreading that word, to the platform that she has, affecting, or having opinions that a lot of people are going to follow. We don't agree with them. We had, our stance as well. So it's not just Adam Minkin's. I think there's a lot of reasons why people choose one route over another instead of really spending the time to learn both sides of it and blend them together. And you said it as well. You went under a lot of training, a lot of manual therapy, but what is with that? A lot of pain science or just communication and neuroeducation that we're taught and emphasized. Hey, you do this, but you need to communicate to the patient. You need to put them first. You need to follow these guidelines, and it's a whole package. But going back to the dogmatic approach with these skills, or techniques, and I guess some of the movement and trying to move, steer away from that, which I totally get. But to say it's unskilled and that anybody could do it is false, because if anybody could do it, every entry level student, every student in PT school would know how to manipulate a neck. And yes, there are adverse reactions, but what are those adverse reactions? Soreness, maybe a flare up of symptoms for 24, 36 hours, right? Versus what are the adverse effects of surgery, medication, even exercise has a higher sudden death rate than manual therapy. So while there is a saying that manual therapy, you don't need to be skilled, but it's more than pressy, pokey, pokey, right? And we need, as clinicians, this skill in clinical decision-making and clinical reasoning to apply these techniques safely to the correct patient at the correct time, so you don't get the really bad one, which is sudden death because you performed a cervical manipulation to somebody who's already experiencing a CAD, and then you kind of put them over the edge. And notice how I worded that, because we can't or don't cause CADs if you screen properly. So that's where I kind of really wanted to kind of, I guess, go with that and mention my last pieces there.
To piggyback off of that, I agree. First things first, I guess you mentioned some things about, some people who are very anti against it, especially against residencies. All right, whatever. If maybe manual therapy didn't work for you, so be it. But like, especially residencies and fellowships, obviously we're biased, but I don't get how you can devalue something that provides higher level of learning. I guess if you're a PhD, maybe doctor of science, maybe you're highly trained and then you did a residency, maybe it won't be as much of a value. But to knock on other things to provide education and help push the profession forward, I always kind of found that was interesting. You see that a lot out there, is where that's another thing that's being demonized, and a lot of it's done by individuals who I think that they monetize their presence on social media, who have hundreds of thousands of followers and are used for their own education purposes. So, if you have only $5,000 in continuing education or so much, and you can spend that on a residency, or you can go spend it seeing XYZ 600,000 follower, person on for one of their courses or one of their mentorships. Yet they devalue the same mentorship that's given in residencies and fellowships. So I always kind of find that funny about that sort of stuff. And another thing about, like, you brought up some things about research, and it's how it's kind of changed and everything like that. I think Mike Reynolds brought up a point that, research back in his day, when he's definitely much more involved, was just trying to find out things that worked. And he's like, now all you find is research that's getting highlighted of things that don't work. We're trying to sweep our own legs out from us. We're trying to constantly throw everything out, versus trying to push and find what, other things that work best. So it's kind of sad that we've gotten to that point, and I feel I'm very happy that I'm not, a young entry level right now, where it's just like, I don't know what to believe or follow a lot of the times. But yeah, so hopefully, everybody takes things with a grain of salt, and again, experience, play around with things. As we mentioned on the show, there's times where I've gone through phases of trying X, Y, and Z at different
Hmm.
points. Now I get more wiser and wiser. It's a blend of everything. I threw out soft tissue for a while because I thought it was not really working, but every once in a while now, when I use it for the right person, I always say it's a ticket. Um, it's what really helped. But I'm not doing soft tissue on the 20 people I see in a day or something. It's one person, if that, maybe one person per week. Um, Maybe not even that. But when I use it, it works because I've played around with things. So yeah, and then the last thing you brought upon it, I think in regards to manual therapy and pain science, I know Brandon and Kyle, who's been on the show, did a great thing on Pain Reframed when we had um, our little webinar series about like integrating manual therapy and pain science education. And Adrian Lowe's made a great book about that I've read some. I think that's the best time to really apply your education of any sorts. What else? When else are you going to do it? To me personally, someone talks to me while I'm exercising, and maybe that's just me. Um, I kind of tune out. Even something as simple as a bike. I'll be able to talk about my day, but especially when it's like higher level learning and understanding and needs a collaborative kind of conversation between patient and therapist. Yeah, I've done it before, but I think the best part is while you're performing those hands-on techniques. And if I look back on how I treat throughout the day, it's a lot of times I have those pain posters. Brandon has them, so we obviously integrate it a lot in our care. It's a lot of times I'm doing some of my techniques, starting some of these conversations, improving confidence, and then leading them right there to those posters. So I think it's a great time to kind of integrate them both. I don't think it's as easy to do just during exercise. I've done it. I don't think we should be the profession just to, hey, sit down in a chair, let me educate you, and then go off on your way, or then go into exercises. I think we're talking about high value based care. Why not combine two interventions at once in manual therapy and exercise, or manual therapy and pain science education, or education altogether? I mean, that's high value right there. It's two in one. So keep that in mind. It doesn't have to be I need a lot time purely for manual therapy. Do a couple things at once. Especially in I see 2 patients per hour. I'm doing manual therapy, and I'm maybe supervising, telling a patient to do something else. So it doesn't have to be purely just that. I think they make great points of in the previous conversations in the podcast and that sort of stuff. Yeah, those guru style manual therapists, which that's all they do. Yeah, that probably needs to be put out to pasture. But I think the modern therapist, which I don't think is highlighted enough, we keep constantly bring back these old guys and these old gurus. Yeah, they're going to be around for a while, and there'll always be some trickling. But let's highlight the new modern therapist that's integrating, all these components and doing the best that we can. And I think that has led to the rise in physical therapy and COVID and everything like that. A lot of professions got hurt, but you talk people around, physical therapy has grown. And I think that's a lot due to what we're giving as a whole package versus, you know, I'm the triage person, you go see 6 different other professionals. But yeah, that's probably last good points I wanted to kind of bring up there.
Yeah, I guess to wrap up, we should be more. We've. I think most people have told or heard that we as a profession are a jack of all trades, right?
Mhm.
Equate that to, and for you baseball fans out there, that the 5 tool player, they can do it all, right? They hit for power, they hit for average, great arm, great defense, they have great speed, right? Versus just being able to do one thing. right? You just hit home runs, but your average is, below the Mendoza line of, 190. So we want to, at least where you and I come from, it's, be good at everything, be good as, everything you can be, and learn where they fit in, and, be able to adapt to, hey, my patient doesn't like being touched. Great. We're going to do hands-off approach. My patient likes being touched or having manual therapy done, and they respond well to it. Great. We're going to do that for a handful of sessions and then, move on. This patient needs to be talked to right now and educated. Cool. We'll do that. Like, being able to do this patient needs to be referred out. We'll refer them out, instead of just going at one thing. Movement only helps so much. So, I think that's all I have. I think you're spent too. So I guess a little short of a podcast today, but more of a whatchamacallit. And Jeremy will post this article and the link as well, so you guys can like it. I'm going to send it out to our newsletter feed and blast on iOSMT. So if you guys aren't following us in there, please give us a follow, subscribe to our newsletter, and you'll get weekly updates. We're starting to do those more and refine that. So you're getting in a good time now if you subscribe to our newsletter. Other than that, Jerry, I think I'm out.
Pretty good. All right. Well, everyone, thanks for tuning in, and cheers, everybody.
Cheers.